because I'm also my presentation twice.
Okay.
That's good.
All right, we're going to go ahead and get started with our next presenter, Hailey, who's going to talk to us about GERD.
Woo! How to use this. All right, hi everyone. I'm Hailey. I am a dietetic intern here at University of Green Bay, Wisconsin Green Bay, and for my fall research review conference, I chose the topic GERD, which is gastroesophageal reflux disease. So in this presentation, I will be covering what GERD is, the signs and symptoms, the risk factors, how it's diagnosed, the common treatment options, and then my 3 research articles, and then a summary at the end. So what is GERD? So gastroesophageal reflux disease occurs when the stomach acid repeatedly flows back into the tube connecting to your mouth, the stomach, so your esophagus. So over here, this is a healthy stomach, and you can see that the sphincter up here is closed, so it keeps that stomach acid inside. But when you have GERD, that sphincter kind of opens up and it weakens, and then it allows for that stomach acid to splash back up into your esophagus, and it can irritate it. An estimated 1 in every 5 American adults suffer from GERD, and GERD is the most common gastrointestinal related diagnosis in the US. It's estimated that pain and discomfort from the acid reflux impacts over 80 million people at least once per month. And why did I choose this? I chose this topic because when I did my clinical rotation at Aurora, I just kept on seeing in the patient's charts, GERD, 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 GERD. And I was like, you know what? I don't really know a lot about that topic, so I'm going to do research on it to see what I can do as a dietitian to help. Common signs and symptoms, heartburn, regurgitating sour fluid, persistent cough, throat discomfort, difficulty breathing, bad breath, or chest pain. So makes sense. Your esophagus is irritated, so you're going to be coughing, bad breath, chest pain. So risk factors of GERD. So there's a hiatal hernia, which I have a picture of it over here. So this is when the upper portion of your stomach kind of sneaks out of this hole in your diaphragm, and then it kind of bulges right there. So instead of it being nice and closed, it's going to be more open, and then you're going to be at more risk for it splashing up into your esophagus. Pregnancy, of course, like the further along you are, the more your insides are going to be pushed all in different directions where they're not supposed to, and it's going to have more pressure on that sphincter area. And then there's connective tissue disorders such as scleroderma, and with scleroderma, more collagen forms, and it can collect in your esophagus, making it kind of more stiff. So it's hard for that sphincter to open and close like it should. Delayed stomach emptying. If you don't have your contents going, digesting as fast as it should, your stomach is going to fill up, and that's going to be more likely to splash out the top of it. And then obesity puts you more at risk because there's just more pressure inside your body, and it's going to put more on that sphincter. There's a delay. How it's diagnosed. The most common is this upper endoscopy. So they have like a tube that's really skinny with a camera on the end, and they'll sneak it through your mouth and then goes down the esophagus, and they can look at that sphincter, how the lining of the esophagus is. Or another way is transnasal. So it's like the same thing, except they don't go through your mouth, they go through your nose. There's also an x-ray they can do. They just make you drink this chalky fluid, and then it kind of glows on the x-ray, so you can see how irritated the esophagus is. And then this one's pretty cool. There's a pH probe test where you wear a little monitor on your belt, and then it goes up into your nose, and then it sits right above the sphincter. So what that records is if there's stomach acid present, for how long, and how bad the damage is. So they just can wear that for anywhere between 1 to 3 days, and then it records everything, and then they can be diagnosed and figure out what foods are causing it. So treatment options, Commonly, there's medications such as antacids, which neutralize the stomach acid. And then there's also proton pump inhibitors or H2 blockers, and those reduce or block acid production. But that isn't always a good thing because the long-term effects of those medications, it can decrease the absorption of vitamin B12, calcium, and magnesium because they're not being absorbed. So now you have all these extra vitamins and minerals in your system, and then it's going to put more strain on your kidneys. So long-term medication use can lead to other problems like CKD and AKI. And then there's also increased risk for infection because if there's not that stomach acid in your stomach to break down all that bad bacteria, good bacteria, you know, that microbiome is just going to be thrown off, and then you're also at risk for infection. But surgery-wise, if you didn't want to do that, there's surgery. And then another common surgery is fundoplication, and they take the upper portion of the stomach, they wrap it around the lower esophagus, and then they sew it up. It's tight enough to allow food to pass through, and then, but it doesn't allow that stomach acid to splash back up. And then same thing over here, this is called a Lynx device. So instead of wrapping around and sewing it, they'll put like these magnetic beads in a ring. They'll put it right at the bottom of your esophagus. And same thing, it'll allow food to pass through, but it kind of prevents this fluid from splashing back up. But why pay for surgery and why take medications and that might lead to other problems when you could just change your diet? That's where the dietitians come in. So my first research article, it was to determine the GERD risk factors associated with dietary habits. It took place from 2006 to 2011 in Poland, and the data on the patient's usual diet was obtained with the use of a questionnaire developed based on literature sources and own observations. There really is a pause. Maybe I'm not pressing hard enough. So in the study, there was 513 people total. One group of patients were aged 18 to 65 who have been recently diagnosed with GERD. And then the control group were healthy adults up to 65 years of age with no GERD symptoms or experiencing GERD symptoms very rarely, like once a month or less. 189 females, 93 males, average age is about 46, average BMI 25. So I got boxes around the similarity of, or the similarities of the groups, because I thought this was a strength of this study, is that the two groups are very comparable. So the amount of females, the percentage of them, very similar. The percentage of males, very similar, age and BMI. It's a very similar group, so it's very nice to compare the two groups when they're alike. Results. The GERD patients reported a relationship between the severity of the symptoms and eating certain foods significantly more often than the control group when eating 3 meals a day. Those certain foods were high in fat, they're sweet, spicy, fried, sour, or fruits. So if you look at this chart, I have a chart here, and in the first column there, that's the odds ratio. So the higher the number, the more likely it is for you to be experiencing those GERD symptoms. So let's just look at like the top 4. So the things that really affected those symptoms are eating 1 to 2 meals a day, eating fatty products, eating sweets, and eating spicy products. And then it kind of goes down from there. But those are like the top 4 things that you might want to watch. Well, that's a study found. Results continued. When the GERD group of patients had only 2 meals a day, they experienced symptoms significantly more often compared to when they're eating 3 meals a day. When the group had 4 meals a day, they experienced symptoms significantly less often compared to eating 3 meals. Patients in both groups had breakfast, dinner, and supper, which is a light meal after dinner. The GERD patients had lunch as an additional meal significantly less often, significantly more often they ate one big meal instead of dinner and supper. Their big meal was more often in the evening than for breakfast. So it seems to be the more meals you eat, the less likely you are to have symptoms, but that's probably because their meals aren't so large. If you have 4 meals a day, they're probably lower in calories. You're not going to the buffet 4 times a day. They were not able to study the regularity of the meals, the speed of eating, or snacking in between meals. They were just looking primarily at the meals in the study. So the study found that patients should be recommended to eat at least 3 meals a day, preferably 4 or 5 if their life can accommodate that, and eat dinner and supper at appropriate times instead of one big meal in the evening. Consumption of fatty, fried, sour, or spicy fruits or sweets, mostly chocolate, also increase the symptoms of GERD, but it's not like you have to completely eliminate those things out of your diet. It's just watching how much and how often they are consuming those. Limitations, I thought this was a positive because I thought that their study groups were very comparable, very similar to one another. However, it was a questionnaire, so it could be recall bias because they weren't eating the food and then marking it down. They were just like, oh yeah, I had this, I had that. So couldn't, it's not exactly super accurate. And then they only surveyed the patient or the participants once. So I thought maybe if you do it 3 or 4 times, it'd probably be more accurate. And they didn't consider different locations, snacking, or is it a specific meal time that's bothering the GERD symptoms, or was it their entire diet? Research article 2. This was to identify the association of total diet and individual meals with GERD. So this took place in 2017, Northwest Iran, and people were referred to the Tabriz Medical Sciences for many different health reasons and were asked questions about GERD. If the person experienced symptoms monthly in the past 12 months, they were referred to a gastroenterologist to confirm or deny the diagnosis of GERD. Both groups were sent home with a 3-day food diary, so they had to fill out 2 weekdays and 1 weekend day. And they had to record the macronutrient and the amount. The study groups, there was 217 people total. The case group was people confirmed that had diagnosis, and the control group were no GERD symptoms within the last 12 months. And then once again, I have boxes because this study also had very comparable groups. So percentage of females are very similar, percentage of males very similar, age very similar. But the only thing that differed significantly between the 2 groups was education. So I thought that was interesting because if you have higher education, you're more likely not to have GERD. If you're illiterate, you're more likely to have GERD. So that was the only main significant difference between the 2. Technology. Okay, so then the result of the meals. So at the top, this is like their total dietary intake. Super similar. The green means super similar. So similar calories, similar carb, similar protein, similar fat. So overall, with their snacks, everything, they have very similar numbers. The only difference was the amount of fat at lunch. So I thought this was interesting too, because here we have a higher number of fat, and that's going to go hand in hand with the GERD symptoms, which kind of goes with the first study. It says the more fat you eat, the more symptoms you're going to have. That correlates with. But when you're looking at the snacks, there was no significant difference between the morning and the before bed snack, but the evening snack, which would be like right after lunch, varied significantly between the 2 groups. So the energy intake, the protein amount, the fat amount, sugar amount, and the percent of carbohydrates were all very, very different. So maybe this is where our problem comes in. What's even more interesting is that the more fat that they consumed in their snack, the less likely they were to have GERD symptoms. So you have to kind of wonder, what kind of fat were they consuming? And if it's not the kind of fat, maybe is it because that they had a higher level of protein? They ate more protein than the GERD group, so maybe the protein and the fat coming together, maybe it digests it differently and doesn't cause that. So of course they answer one question and then it makes you ask for more. But something interesting to think about. So total diet and individual meals. Lunch was the largest amount of fat and was the main meal amongst most individuals. So largest meal, filling up your stomach, lower esophageal sphincter relaxation, GERD. Evening snack lowered the GERD symptoms. So it's unclear the different forms of fat were consumed with different macronutrients. Limitations, I thought this was also a positive study. Like I said before, there are two groups that they compared were very similar. However, it was clinical based. They were all referred to the same medical science university hospital. So it's not an accurate representation of the population. Misclassification might exist when the endoscopy was not offered to all the patients. So did the case group really have GERD? They weren't exactly all tested. Could not investigate the relationship between diet and reflux severity. I think if they did like the pH probe test, that would have been cool because then they could know how bad it is and they could record their food as they're wearing it. Location. A lot of people in this study, their biggest meal was lunch, but I don't know about you guys, but my biggest meal is dinner. I feel like that's very common for people in the United States is to come home from work and then just pig out and eat dinner. So would that change the results? And then did the individuals change their diet because they were keeping track? When I was in school and I had to do the 2 weekdays and 1 weekend day, I specifically subconsciously ate better just so it looks better on paper, I guess. Like, I know you're not supposed to do that, but just like subconsciously, I think people might have done that. So for my third article, they wanted to find what beverages were associated with the onset of GERD symptoms. This is an ongoing prospective cohort study, but the data for this was taken between 2007 to 2013. These surveys were all over the United States of America, and the questionnaires were sent out every 2 years to provide lifestyle exposures, medical history, newly diagnosed disease, age, weight, height, BMI, physical activity per week in hours, smoking, diabetes, and other medications. So you gotta keep track of all of that. So this study population was over 116,000 people to begin with, and they were all female registered nurses. They started the study from 25 to 42 age for years. And then they were excluded if they had GERD symptoms more than once a week or had any kind of history of cancer other than skin cancer, reported regular use of PPI or H2 blockers that's going to affect that, stomach acid, or failed to follow up and send in their survey. So after all of that getting excluded, we ended up with just over 48,000 women. So participants were reported average food and beverage intakes during the preceding year through a food frequency questionnaire. So they were asked in the last year, how often have you had heartburn or acid reflux? And they could answer none, less than 1 month, less than 1 time per month, about 1 month, about once a week, several times a week, or daily. Questionnaire items on beverage intakes included items on coffee, tea, soda, juice, milk, and water. So food items included common dietary risk factors for GERD symptoms such as tomato, chocolate, citrus, fat, and fiber. So coffee, tea, and soda consumption were all associated with the increased risk of GERD symptoms. So I have a chart here, and these are servings per day. So as the servings go up, the number usually goes up. They're kind of a little bit off, but usually the more you drink, the higher the number, the more at risk you are. So, and then they also found that women with the highest intake of coffee were more likely to be current smokers than women with the lowest intake. Women with the highest intake of tea were more active and less likely to smoke. Women with the highest intake of soda were less active, more likely to have diabetes, and more likely to be on prescription medications that relax that sphincter. So this was super interesting to me because a lot of the studies out there say, oh, just avoid caffeine. But in this study, that's not exactly the case. They tested caffeinated and decaffeinated, and I outlined the ones that had a higher risk to cause those symptoms. So more times than not, decaffeinated coffee is almost worse. Decaffeinated tea is worse all around, all the way across. Soda, decaffeinated, also bad. So, I mean, when people say, oh, just avoid caffeine, it's not just the caffeine. It's something else, but what? Other common beverages also evaluated other common beverages like water, milk, and juice. There was no association between these beverages and the GERD symptoms. Conducted substitution analysis examining whether the replacement of coffee, soda, or tea with water would lead to a reduction of risk. So I made this chart here, and then I put the previous values down here. And then by drinking water, it went down all the way. All the numbers are lower. Drink water. I mean, you don't have to always drink water. This is just substituting just one serving, 2 servings, 3 servings. So even if you just substitute 1 glass of water for your cup of coffee, you can still have a cup of coffee, but drink water too. It's going to lower those symptoms. Overall findings, increased risk of GERD symptoms if you drink coffee, tea, or soda, even get decaffeinated. No significant association between juice, milk, and water. Substitution of coffee, tea, or soda with water led to a slight reduction in risk. Coffee and soda showed minimal change between caffeine status and surprisingly a stronger association of GERD symptoms between decaffeinated tea. So is it the kind of tea? I mean, that's causing these numbers? I mean, were they drinking green tea, herbal tea, black tea? Like, so is the kind of tea? Otherwise, another thing that could have been causing it is peppermint. A lot of teas have the ingredient peppermint in it, so maybe it was peppermint tea that they're drinking, which caused those numbers to be off. Or is it the pH of these beverages? So, answered one question, 4 more. Limitations, I thought this was also a positive study. They did have a large group of people, which is awesome. However, the study was limited to mainly white women between the ages of 42 to 62. So men get GERD too, but I'm guessing just since this is a study with registered nurses, there's more men and registered nurses now, but I think that they would have just, it would have looked silly if you only had 1,000 men and then 30,000 women. So I think they just kind of like push the men out of it and just like, oh, we're just going to do women this time. So that was kind of a downfall. I wonder if it would change it if they did have men in their study. And then the questionnaire was used instead of invasive testing such as pH measurement or an upper endoscopy. So they didn't, it's just a questionnaire. They didn't actually drink a soda with their little pH monitor in there. So it's hard to tell. And then the food frequency questionnaires are subject to measurement error. They didn't capture the portion size or the timing of those beverages in relation to bedtime. Sometimes I drink coffee before bed. Like what that probably would have had me GERD symptoms. So my takeaway, my implications for practice. So GERD affects 20% of the population. That is a lot. And studies suggest patients should eat at least 3 meals a day, preferably 4 or 5, more frequent, smaller meals. Keep the contents of your stomach lower so it's not about to splash out the top. There's only so much room in there. Limit their intake of fatty, fried, sour, spicy food, fruits, or sweets, mostly chocolate. Doesn't mean you can never have them again. That overwhelms people. You can have it, just small portions, and not every day. And then they also want to limit their intake of coffee, soda, and tea, both decaf and regular. The more water substituted into the diet, the more reduction of the symptoms will occur. Patients will also be at more risk for symptoms if they have a higher BMI, use tobacco, have diabetes, or use medications that relax that sphincter. Questions? I hate this thing.
So you mentioned in your inpatient rotation, you saw GERD a lot on the charts. And I thought it was really interesting that in the study, the only outlier was education. So I was just curious if your facility provided education to GERD patients.
So a lot of the times, more than not, the patient doesn't even know they have GERD. So like you can go in there and you can ask about GERD and you go, what is that? And then we talk about what it is and if they have acid reflux, and a lot of times they're like, no, I don't have that. So I don't know if it's misdiagnosed or if they just were never educated on it, but it varies people to people. Some people, they have it and it doesn't really bother them. They're like, oh yeah, that's normal. And they just go on with their day-to-day life. And then other people, they need that surgery because, I mean, it just bothers them. It's hard for them to eat. You know, they're coughing all the time. It's sore. So it varies person to person. But if they asked for education, we would be happy to give it to them.
And then I just wanted to applaud you for including the differences in like the caffeinated versus non-caffeinated, because I think it highlights how physicians just give blanket statements about nutrition. Well, just avoid caffeine and you'll be fine, or avoid all white foods and you'll be fine. So I applaud that you like dug into that further.
Yeah, for sure. I thought that was very surprising. That's why I was just like, wow. Because I mean, I read online, you know, it always just says caffeine, but even decaffeinated is still, you know, they come back in with the same symptoms and they wonder why. Well, no coffee, no tea, no soda. Probably be better.
Probably agree.
Back to do. Drink water and juice or 1 cup a day, you know.
How common was the fundoplication surgery? Did you see it often, or was it more so patients being treated just with medications?
More common medications, but I'm assuming that when the medications don't work very well, that they're going to go to surgery. So I was at Aurora for 8 weeks, and I think there was about 3 fundoplications. So I mean, it's quite common for sure. With how common it is in people's charts, it kind of depends. Yeah, I don't really know. I don't know. Depends on the person, I guess.
Yeah.
But it was common. It's scary common. And I wonder if, you know, if we educated more patients, would they get off those meds or would they not get surgery? The doctors are like, no. Like, that's my point. So we'll see. We can do what we can, and they can try to persuade them into surgery.
Great job, Hailey.